Welcome to the deep dive. Today, we're plunging into, well, the most incredible, tirelessly beating engine inside each of us, the human heart.
It really is amazing.
For centuries, people literally believed the heart was the seat of intelligence, maybe even our emotions.
Right, the old poetic view.
And while we know now the brain handles that, it's still amazing how much our emotions do affect its rhythm. When your heart pounds or skips a beat, you feel that deep connection.
Absolutely.
Okay, let's unpack this. Our mission today really is to cut through the complexity. We're using the Human Anatomy and Physiology 10th edition as our main guide here.
A solid source.
We're basically extracting the most important nuggets of knowledge from it, helping you quickly get truly well-informed about the heart's amazing structures, its vital functions, and some really critical clinical insights too.
Think of it as your fast track.
Exactly. Your shortcut to understanding this incredible organ.
And that's key because the heart isn't just, an amazing standalone piece of kit. It's the central pump of your entire cardiovascular system. That whole network of vessels, it continuously delivers oxygen and nutrients to every single cell in your body while whisking away waste. It's just an incredibly elegant non-stop transport system.
Totally elegant. So let's start with its blueprint, the heart's anatomy, its coverings. It's surprisingly modest in size, isn't it?
It really is. Roughly the size of a fist.
Fist-sized, yet its strength and endurance are just off the charts. It's tucked snugly there in the center of your chest, leaning slightly left.
Resting right on your diaphragm.
Yeah. And if you feel your chest just below your left nipple, that little thump you might feel, that's the very tip, the apex of your beating heart touching the chest wall. Pretty cool.
And what's fascinating here is that even though it's one organ, functionally, it works like two separate pumps, side by side.
Two pumps.
Yeah, each managing a distinct circulation circuit. The right side is dedicated to the pulmonary circuit.
To the lungs.
Exactly. It receives oxygen, poor blood from your body, and pumps it directly to the lungs, picks up oxygen, drops off CO2.
Got it. And the left side?
The left side handles the systemic circuit. It gets that fresh, oxygenated blood from the lungs.
And sends it out.
Pumps it out through the aorta to supply every single tissue. Brain, toes, everywhere. You can see this laid out nicely in figure 18.1, by the way.
Okay. And for something so vital, it needs, serious protection, right?
It absolutely does. Surrounding the heart is this clever double-walled sac. It's called the pericardium.
Pericardium.
The outermost layer is tough, fibrous, like a strong shield. It anchors the heart in place and, really importantly, prevents it from overfilling with blood.
Stops it from stretching too much.
Precisely. Then, deeper to that, there's a thin, slippery serous layer. It actually has two parts.
Two parts.
One lining the fibrous sac and one directly on the heart's surface itself. We call that the epicardium.
Okay, epicardium.
And between these two serous layers is a tiny space, the pericardial cavity. It's filled with just a film of serous fluid.
Like a lubricant.
Exactly like a lubricant. It lets the heart beat and move freely without any friction. Think of it like oil in an engine allows smooth, unimpeded motion.
Makes sense.
Now, sometimes this protective sac can get inflamed. That condition is called pericarditis.
Pericarditis.
It roughens up the surfaces, and a doctor can actually hear a distinct creaking sound, like rubbing leather. Often comes with deep chest pain.
Ouch.
And in really severe cases, too much inflammatory fluid can build up in that cavity. That leads to cardiac tamponade.
Tamponade, like a plug.
Literally a heart plug.
Yeah.
The excess fluid compresses the heart, squeezing it so it can't pump effectively. It's an emergency. Physicians have to drain that fluid quickly to relieve the pressure.
Wow. That's incredible how just a bit of extra fluid can cause such a massive problem. So, okay, beyond the coverings, what's the actual heart wall made of?
Right. The wall itself has three layers. The outer layer is the epicardium. That's the one we just mentioned, the visceral part of the serous pericardium. Then there's the myocardium. That's the big one, the muscle heart. It forms the bulk of the wall and does all the powerful contracting.
And workhorse layer.
Exactly. And finally, the innermost layer is the endocardium, a thin sheet lining the chambers.
Let's zoom in on that myocardium then, the muscle part.
Good idea. It's made of these really unique branching cardiac muscle cells. They're kind of woven together by a dense network of crisscrossing connective tissue fibers. These fibers form bundles, often spiral or circular. You can see this in figure 18.4.
Okay.
This network is called the fibrous cardiac skeleton.
Fibrous skeleton.
Yeah.
Sounds sturdy.
It is. It doesn't just anchor the muscle fibers, it also acts as an electrical insulator.
Insulator. Why is that important?
It's crucial because it limits the spread of electrical signals. It ensures they travel along specific orderly pathways, not just randomly through the muscle. This directed flow guarantees the heart contracts in a highly coordinated and efficient way, not just a twitch.
Ah, coordination.
Yeah.
Makes sense. Now let's metaphorically open up this amazing organ and look at its internal plumbing. We all know the heart has 4 chambers, right?
4 chambers, yes. 2 smaller receiving chambers up top, the atria,
Receiving rooms?
and 2 larger, powerful pumping chambers down below, the ventricles.
The powerhouses.
You got it. The atria are relatively thin-walled. Their main job is just to push blood downstairs into the ventricles.
So not much heavy lifting there.
Not really. The right atrium is quite busy, though. It takes in all the oxygen-poor blood returning from your entire body via 3 large veins, the superior vena cava, inferior vena cava, and the coronary sinus.
Okay. And the left atrium?
The left atrium receives freshly oxygenated blood coming directly back from the lungs via 4 pulmonary veins.
Ready for the big push?
Exactly. And then we get to those powerhouse chambers, the ventricles. These are the discharging chambers, the actual pumps of the heart. The right ventricle pumps blood just to the lungs via the pulmonary trunk. The left ventricle, though, that dominates the lower back part of the heart.
That's the big one.
That's the big one. It ejects blood into the massive aorta, ready to distribute that oxygen-rich blood everywhere else.
Okay, now here's something I remember reading. The walls are different thicknesses.
Yes. Here's where it gets really interesting, structurally and functionally. The left ventricle's wall is about 3 times thicker than the right ventricle's wall.
3 times. Why?
It's a critical adaptation. Think about the circuits. The systemic circuit, which the left ventricle powers, is much, much longer than the pulmonary circuit.
Right, it goes everywhere.
Everywhere. And it faces about 5 times more resistance, more friction. So the left ventricle has to generate much, much more pressure to force blood through that entire system. It's simply a far more powerful pump. Its cavity is also more circular, while the right's is kind of crescent-shaped.
Yeah.
Check out figure 18.9 for that comparison.
Fascinating. Okay, so chambers pump, but how does the blood know which way to go? That's the valves, right?
Precisely. To ensure blood only flows in one direction, the heart relies on a sophisticated system of 4 valves. These crucial structures open and close passively, just based on pressure changes within the chambers.
4 valves. What are they?
There are 2 main sets. First, the atrioventricular valves, or AV valves. They're located between the atria and ventricles.
Between top and bottom chambers.
Exactly. You have the tricuspid valve on the right side, 3 flaps, and the mitral or bicuspid valve on the left, 2 flaps.
Mitral. Like a bishop's mitre.
That's the origin of the name, yeah. These valve flaps are anchored by these tiny white collagen cords, often called heartstrings.
Chordae tendineae. I remember that term.
That's them. Chordae tendineae. They attach to these cone-shaped papillary muscles sticking out from the ventricular walls.
Okay, so that's the AV valves. What's the second set?
The second set are the semilunar valves, or SL valves, aortic and pulmonary.
Where are they?
They guard the bases of the large arteries leaving the ventricles, the aorta, and the pulmonary trunk. Each one has 3 little pocket-like cusps, shaped kind of like a half-moon, hence semilunar.
It's such an elegant mechanism when you think about it. How do the AV valves stop backflow?
Well, when the ventricles contract, the pressure inside them skyrockets. This rising pressure pushes blood up against the AV valve flaps, forcing them shut.
Okay.
And those heartstrings, the chordae tendineae, along with the papillary muscles, act like guy wires on a tent. They tense up.
Preventing the flaps from blowing upwards.
Exactly. Preventing them from everting or blowing inside out back into the atria, like an umbrella getting caught in a strong gust of wind. Figure 18.7 shows this really well.
Neat analogy. And the SL valves.
They work based on pressure, too, just the other way around. They open when the ventricles contract and pressure inside the ventricle exceeds the pressure in the arteries. Blood rushes out.
Okay.
Then, when the ventricles relax, the pressure inside them drops rapidly. Blood in the arteries starts to flow backward toward the heart.
But it gets caught.
It gets caught. It fills those pocket-like cusps of the SL valves, forcing them to snap shut. Bang! No backflow into the ventricles. Figure 18.8 illustrates that.
Makes sense. But wait, you mentioned no valves where the big veins enter the atria. Why no backflow there?
That's an important observation. It's an important omission, the textbook notes. Basically, backflow is minimal, partly due to the inertia of the blood already moving forward, and partly because the atrial muscle slightly compresses those venous entry points when the atria contract. It's usually not a significant issue.
Interesting.
Now, this brings us back to clinical stuff. Valve problems are pretty significant concerns.
Right, if they don't work properly.
Exactly. An insufficient or concomitant valve is one that fails to close completely. It leaks.
So blood flows backward.
Yeah. It causes backflow or regurgitation. Doctors often hear this as a swishing sound through a stethoscope as the blood churns.
Okay. And the other problem?
The other main issue is valvular stenosis. Here, the valve flaps become stiff, often due to calcium deposits or scar tissue after infection.
Stiff, so they don't open fully.
Correct. The opening is narrowed, restricting blood flow through the valve. This forces the heart to contract more forcibly to push blood past the obstruction, often produces a high-pitched sound or click.
So both leaky valves and stiff valves make the heart work harder.
Absolutely. Both conditions increase the heart's workload significantly and can weaken it over time, potentially leading to heart failure. The good news is we now have pretty effective valve replacement options using mechanical or biological valves.
That's good to know. Okay, so with that intricate plumbing chambers, valves understood, maybe walk us through the actual pathway of blood again, like follow a drop of blood.
Sure. Let's trace it using focus figure 18.1 as a guide. Oxygen-poor blood from your body enters the right atrium.
Okay, top right.
Goes through the tricuspid valve into the right ventricle.
Bottom right.
Right ventricle pumps it through the pulmonary valve into the pulmonary trunk, which splits and carries it to the lungs.
Where it drops off CO2 and picks up oxygen.
Bingo. Then, this freshly oxygen-rich blood returns from the lungs via the pulmonary veins to the left atrium.
Top left.
Flows through the mitral valve into the powerful left ventricle,
Bottom left, the big pump.
which then contracts forcefully, ejecting that oxygenated blood through the aortic valve into the aorta
And out to the rest of the body.
to nourish every tissue. Then the cycle repeats. Billions of times in a lifetime. It's worth noting, too, that the pulmonary circuit vessels are unique. The arteries carry oxygen-poor blood, and the veins carry oxygen-rich blood, the opposite of the systemic circuit.
Right. That's a key difference. Okay, here's a question that always bugged me. This organ is literally filled with blood, right? Swimming in it. How does the heart muscle itself get its own nourishment? It's not just soaking it up from the inside, is it?
No, that's a great question and a common misconception. The heart muscle is too thick for diffusion from the chambers to work. It needs its own dedicated blood supply. That's where the coronary circulation comes in.
Coronary.
Yeah.
Like a crown.
Exactly. It's the heart's own functional blood supply, and it's actually the shortest circulation circuit in the body. The left and right coronary arteries branch right off the base of the aorta, just above the aortic valve.
Okay.
They encircle the heart, kind of like a crown, and there are major branches like the anterior interventricular artery, often called the LAD, or widowmaker, the circumflex artery, the right marginal artery, the posterior interventricular artery dive into the heart muscle, supplying specific regions.
So they feed the muscle tissue directly.
And interestingly, these vessels deliver most of the blood to the heart muscle when the heart is relaxed during diastole.
Why that?
Because during contraction, or systole, the contracting myocardium actually squeezes and compresses these coronary arteries, reducing the flow. So relaxation is feeding time for the heart muscle.
Huh. Never thought about that.
And this leads directly to a very serious clinical issue,
Right.
a blockage in this coronary circulation.
Heart attack.
Right. A temporary deficiency where the heart cells are weakened by lack of oxygen but don't actually die causes chest pain called angina pectoris, literally choked chest. It's a warning sign.
Okay.
But if the blockage is prolonged and severe, it causes a myocardial infarction, or MI, what we commonly call a heart attack.
Where the muscle cells actually die.
They do. The tissue dies and is eventually replaced by non-contractile scar tissue. This weakens the heart pump. And because the left ventricle does most of the work, damage there is particularly serious, often life-threatening.
Scary stuff. So how does the used blood get out of the heart muscle?
Good follow-up. After the heart muscle uses the oxygen and nutrients, the deoxygenated blood is collected by a network of coronary veins, the great cardiac vein, middle cardiac vein, small cardiac vein.
Okay.
These veins roughly follow the paths of the coronary arteries, and they all eventually drain into a large vessel on the back of the heart called the coronary sinus.
Coronary sinus. And where does that...
Empty. Conveniently, it empties its oxygen-poor blood directly back into the right atrium, along with the blood returning from the rest of the body. So it completes the heart's own internal blood cycle.
Wow. A whole circulation just for the heart itself. Okay, so we've explored the big picture anatomy, the plumbing, the heart's own supply lines. Let's go microscopic now. What truly makes cardiac muscle so special? We know it's striated, like skeletal muscle. Uses the same basic contraction mechanism.
Indeed, the sliding filament mechanism is the same, but there are crucial differences in structure and function. Cardiac muscle cells are quite different from the long, cylindrical fibers of skeletal muscle. They are short, fat, branched, and interconnected. Each cell usually has just one, maybe two nuclei.
Branched and interconnected. How?
This is absolutely key, through structures called intercalated discs. If you look at figure 18.11, they appear as dark staining junctions where the cardiac cells meet end to end.
Intercalated discs. Okay.
Yeah. Think of them as super strong, super fast connection points. They literally zip the cells together. They contain two important things: desmosomes, which act like rivets, preventing the cells from pulling apart during forceful contractions.
Drawn connections.
And critically, gap junctions. These are like little electrical tunnels. They allow ions, and therefore the electrical current, to pass directly from one cell to the next almost instantly.
So the signal just jumps across.
Exactly. This electrical coupling means the entire heart muscle, or at least the entire atrial muscle mass and the entire ventricular muscle mass, acts like one giant coordinated unit. We call it a functional syncytium. It contracts all together in perfect sync.
Wow. Functional syncytium. Got it. What else is special?
Cardiac muscle cells are packed, absolutely packed, with large mitochondria. They make up maybe 25–35% of the cell volume.
Why so many mitochondria?
Because the heart relies almost exclusively on aerobic respiration to generate ATP. It needs a constant, huge supply of energy to beat continuously. This abundance of mitochondria makes cardiac muscle incredibly resistant to fatigue. It just doesn't get tired like skeletal muscle does.
Needs to keep going. 247.
Right. Also, the way it handles calcium is a bit different. It needs extracellular calcium to trigger the release of much larger calcium stores from its internal sarcoplasmic reticulum, and maybe the most important functional difference. Cardiac muscle cannot undergo tetanic contractions. It can't just seize up and stay contracted like a cramped skeletal muscle can.
Why not? That seems important.
Vitally important. Its absolute refractory period, the time it needs to reset before it can be stimulated again, is nearly as long as the contraction itself. This ensures that the heart must relax and refill with blood between beats. Imagine if it just locked up solid, it wouldn't be a pump anymore.
Right, it needs that fill time.
Okay,
that's fascinating. And you mentioned earlier, the heart can beat on its own, no nerves required. How does that work?
It's true. The heart's ability to depolarize and contract is intrinsic, meaning it originates within the heart itself. It doesn't need signals from the nervous system to initiate a beat.
So how does it start itself?
This self-starting property comes from its intrinsic cardiac conduction system. This is a network of specialized non-contractile cardiac cells, often called pacemaker cells.
Pacemaker cells, like the name suggests.
Exactly. These cells are unique because they don't have a stable resting potential like nerve or regular muscle cells. Instead, their membrane potential continuously depolarizes, drifting slowly upward toward the threshold for firing an action potential. This is called the pacemaker potential. You can see this in figure 18.12. Once they hit threshold, boom, they fire. Then they repolarize and immediately start drifting up again, automatically.
They just keep going on their own rhythm.
Precisely. Let's walk through the sequence of excitation following figure 18.13a. It starts at the sinoatrial node, or SA node.
The main pacemaker.
That's the one. Located in the wall of the right atrium, near the entrance of the superior vena cava. It typically generates impulses at about 75 times per minute in a resting adult, setting the basic heart rate or sinus rhythm.
Okay, SA node fires. Then what?
The impulse spreads rapidly through the atrial muscle via those gap junctions, causing the atria to contract. It also travels to the atrioventricular node, or E node, located in the lower part of the interatrial septum.
The AV node. Is that important?
Crucial. At the AV node, the impulse encounters a slight delay, about 0.1 second.
No delay. Why?
This pause is absolutely vital. It gives the atria enough time to finish contracting and empty their blood completely into the ventricles before the ventricles get the signal to contract. Ensures proper filling.
Timing is everything.
It really is. From the AV node, the impulse enters the AV bundle, also known as the bundle of His. This is the only electrical connection between the atria and the ventricles. Remember that fibrous skeleton insulator?
Right, it blocks other paths.
Exactly. The AV bundle then splits into the right and left bundle branches, which travel down the interventricular septum toward the heart apex.
Down the middle.
And finally, these bundle branches give rise to the subendocardial conducting network, or Purkinje fibers. These penetrate deep into the ventricular walls and apex.
Purkinje fibers.
Yeah,
They reach the actual muscle cells.
they do. They transmit the impulse very rapidly to the ventricular muscle cells, causing them to depolarize and contract. And the activation happens in a specific sequence, starting near the apex and sweeping upwards towards the base.
Like wringing out a towel.
That's a great analogy, a ringing motion. This pushes blood superiorly up towards the large arteries exiting the top of the heart. Very efficient ejection.
Wow. An incredibly coordinated electrical sequence. So when this system goes wrong, that's when you get problems like arrhythmias.
Exactly. Arrhythmias are just irregular heart rhythms. They can range from benign extra beats to serious issues. One of the most dangerous is fibrillation.
Fibrillation, what's that like?
It's rapid, irregular, completely uncoordinated contractions. The heart muscle just quivers chaotically like a squirming bag of worms, as the textbook puts it. It stops being an effective pump. Ventricular fibrillation is fatal if not treated immediately.
And that's where defibrillation comes in.
Yes. Defibrillation uses a strong electrical shock to depolarize the entire heart simultaneously. The hope is that this wipes the slate clean, allowing the SA node to hopefully regain control and reestablish a normal coordinated rhythm.
A reset button.
Kind of, yeah. We also see issues like heart block, where damage to the AV node or AV bundle interferes with signal transmission from atria to ventricles. Depending on the severity, this might require an artificial pacemaker to be implanted, which takes over the job of pacing the ventricle.
Makes sense. So the heart sets its own pace, but obviously things change that pace, right? Nerves, hormones.
Absolutely. While the intrinsic conduction system sets the basic beat, external factors, particularly your autonomic nervous system, constantly modify this rhythm to meet your body's needs.
Like speeding up for exercise.
Precisely. Your sympathetic nervous system, the fight-or-flight system, acts as the heart's accelerator. It releases norepinephrine, which increases both the heart rate by making the pacemaker cells fire more quickly, and the force of contraction by enhancing calcium entry into the muscle cells. Think figure 18.22.
Okay, accelerator. What's the brakes?
That's the parasympathetic division, primarily via the vagus nerves. It acts as the brakes, releasing acetylcholine, which slows down the heart rate by hyperpolarizing the pacemaker cells. Interestingly, the parasympathetic system has much less effect on the force of contraction, especially in the ventricles, because the nerve fibers don't innervate the ventricular muscle as much.
So mostly affects rate.
Mostly rate. And actually, at rest, the parasympathetic system usually dominates. It constantly sends inhibitory signals to the SA node, keeping your resting heart rate slower than the SA node's inherent firing rate of maybe 100 beats per minute. This parasympathetic influence is called vagal tone.
Vagal tone. Interesting. So how do doctors actually see this electrical activity? They can't just look inside, right?
Yeah, right. That's where the electrocardiogram, or ECG, sometimes EKG, comes in. It's a fantastic diagnostic tool. It's essentially a graphic recording of the electrical activity of the heart.
A picture of the electricity.
Not quite a picture, but a tracing. It's a composite record of all the action potentials being generated by all the heart cells at any given time, detected by electrodes placed on the skin.
Okay, and those wavy lines mean something.
They absolutely do. A typical ECG tracing shows 3 main deflection waves. You can see this clearly in figure 18.16.
PQRST.
You got it. The first little bump is the P wave. This represents the depolarization of the atria just before they contract.
Atrial activity.
Then comes the big, complicated spike, the QRS complex. This signifies the depolarization of the ventricles right before they contract. It's much larger because the ventricular muscle mass is so much bigger than the atrial mass.
Makes sense. Where's atrial repolarization?
Good question. It actually happens during the QRS complex, but the electrical signal is much smaller and gets completely obscured by the large ventricular depolarization signal, so it's hidden.
Okay, and the last wave?
The last wave is the T wave. This represents the repolarization of the ventricles as they electrically reset before the next beat.
So P is atrial firing, QRS is ventricular firing, T is ventricular resetting.
That's a good summary. And doctors also look closely at the intervals between these waves, like the PR interval, the ST segment, the QT interval. The timing and shape of these waves and intervals provide crucial diagnostic information.
How so? What can they tell?
Changes can reveal a lot about heart health. For example, looking at figure 18.18, you can see how an enlarged R wave in the QRS complex might hint at enlarged ventricles. An ST segment that's elevated above the baseline or depressed below it can indicate cardiac ischemia, lack of blood flow to the heart muscle. A prolonged QT interval might suggest a repolarization abnormality that increases the risk of dangerous arrhythmias. It's a powerful window into the heart's electrical health.
Wow. So much information, those little squiggles.
Mhm.
Okay, we've covered electrical. Let's connect it back to the actual pumping action, mechanical events, the cardiac cycle.
Exactly. The cardiac cycle includes all the events associated with blood flow through the heart during one complete heartbeat. One cycle involves both contraction, which we call systole, and relaxation, which is diastole.
Systole and diastole, contraction and relaxation.
Right. Let's trace the main phases, focusing on pressure and volume changes, like in figure 18.19. It starts with ventricular filling, which happens during mid to late diastole when the heart is relaxed.
Blood just flows in.
Mostly passively, yeah. The AV valves are open, blood flows from the atria into the ventricles. Then, right at the end of diastole, the atria contract, giving a final push to squeeze the last bit of blood into the ventricles. This brings the ventricles to their maximum volume for that cycle, the end diastolic volume, or EDV.
Full tank. Then what?
Then comes ventricular systole, the contraction phase. It actually starts with a very brief period called the isovolumetric contraction phase.
Isovolumetric. Same
Yep,
volume.
exactly. The ventricles start contracting, pressure shoots up, and this slams the AV valves shut. But the pressure isn't yet high enough to open the SL valves leading out to the arteries. So for a split second, all four valves are closed and the ventricles are contracting, but the volume of blood inside isn't changing. Pressure builds rapidly.
Okay, pressure buildup.
Until the ventricular pressure exceeds the pressure in the aorta and pulmonary trunk. Then, bang! The SL valves are forced open, and we enter the ventricular ejection phase. Blood rushes out of the ventricles into the arteries. Ventricular pressure peaks here.
Ejecting the blood. Makes sense.
Ah.
What happens after ejection?
Then the ventricles start to relax, entering early diastole. This begins with another brief phase called isovolumetric relaxation.
Same volume again.
Yep. As the ventricles relax, pressure inside them falls rapidly. When ventricular pressure drops below the pressure in the arteries, blood starts to flow back, snapping the SL valves shut. You actually see a little pressure bump in the aorta called the dicrotic notch when this happens. Now, again, all four valves are briefly closed. The volume of blood left in the ventricle after contraction is the end systolic volume, or ESV.
So EDV minus ESV is how much got pumped out.
Precisely, that's the stroke volume. Anyway, during isovolumetric relaxation, pressure continues to plummet until it drops below the pressure in the atria. At that point, the AV valves drift open and ventricular filling starts all over again.
And the whole cycle repeats. How fast does this happen?
It's quick. For a typical resting heart rate of, say, 75 beats per minute, the entire cardiac cycle takes only about 0.8 seconds.
Less than a second for all that. Incredible. And this precise opening and closing of valves, that's what makes the heart sounds we hear, the lubbed up.
Exactly. Those familiar lubbed up sounds are associated with the heart valves closing. The first sound, the lub, is louder and longer. It comes from the AV valves, tricuspid and mitral, closing at the beginning of ventricular systole.
Lub, AV valves closing.
Right. The second sound, the dup, is shorter and sharper. It's caused by the SL valves, aortic and pulmonary, snapping shut at the beginning of ventricular relaxation, or diastole.
Dup, SL valves closing.
You got it. So, lubbed up, systole, diastole, lubbed up.
And if the sounds are abnormal, like murmurs.
Right. Heart murmurs are abnormal heart sounds, often indicating valve problems. They usually result from turbulent blood flow, blood hitting obstructions, or flowing backward through leaky valves.
We talked about leaky and stiff valves earlier.
Exactly. An insufficient or incompetent valve that doesn't close properly creates a swishing sound as blood backflows or regurgitates through the leaky valve.
Squishing leaky valve.
And a stenotic valve, which is stiff and narrowed, restricts forward flow. This often produces a characteristic high-pitched sound or click as blood is forced turbulently through the narrow opening. Both murmurs tell a doctor that a valve isn't working quite right and the heart might be under strain.
Okay. So we've got the cycle, the sounds. How do we actually quantify how well the heart is performing its main job, pumping blood?
The key measure for that is cardiac output, usually abbreviated as CO.
Cardiac output, what is it?
It's simply the amount of blood pumped out by each ventricle in 1 minute. It tells you how much blood the heart is circulating per minute.
Okay. How do you figure that out?
It's a straightforward calculation. Cardiac output, CO, equals heart rate, HR, times stroke volume, SV.
CO equals X SSV.
Yep. Heart rate is just beats per minute. Stroke volume is the volume of blood pumped out by one ventricle with each beat. Remember, EDV minus ESV.
Got it. So what's a typical cardiac output?
For an average resting adult, the heart rate is around 75 beats per minute, and stroke volume is about 70 milliliters per beat. So CO is roughly 75 by 70, which equals 5,250 milliliters per minute, or 5.25 liters per minute.
5.25 liters. That's basically your entire blood volume being pumped around every minute.
Pretty much. Your total blood volume is usually 5-6 liters. So at rest, your entire blood supply circulates through your body about once every minute. During exercise, CO can increase dramatically, maybe 4 to 5 times that, even up to 7 times in elite athletes.
Incredible. So CO depends on heart rate and stroke volume. What controls the stroke volume? How much blood gets pumped per beat?
Excellent question. Stroke volume, SV, is regulated by 3 main factors. You can see these laid out in figure 18.21. They are preload, contractility, and afterload.
Preload, contractility, afterload. Okay, what's preload?
Preload is essentially the degree to which the cardiac muscle cells are stretched just before they contract. Think of it as the load before contraction.
How stretched the muscle is.
Exactly. And this relates directly to a fundamental principle called the Frank-Starling law of the heart.
Frank-Starling law.
It states that within physiological limits, the more the cardiac muscle fibers are stretched, the more forcefully they contract. So the higher the preload, the higher the stroke volume.
More stretch, stronger contraction, more blood pumped.
Precisely. And what determines how much the heart muscle is stretched? The most important factor is how much blood returns to the heart between beats the venous return. More blood returning stretches the ventricles more, leading to a stronger contraction and higher stroke volume. It's a beautiful self-regulation mechanism.
Okay, that's preload. What about contractility?
Contractility refers to the contractile strength achieved at a given muscle length. It's about how hard the heart muscle squeezes, independent of the stretch or preload.
So making the muscle itself stronger.
Or rather, making it contract more forcefully at any given starting stretch. Increased contractility means the heart ejects more blood per beat, so the end systolic volume, ESV, decreases, and stroke volume, SV, increases.
What increases contractility?
The biggest factor is sympathetic nervous system stimulation, that norepinephrine and epinephrine we mentioned earlier. They increase calcium levels inside the muscle cells, leading to more forceful contractions. Certain hormones like thyroxine and drugs like digitalis are also positive inotropic agents that increase contractility. High levels of calcium ions in the blood do too. Conversely, things like acidosis or high potassium levels decrease contractility.
Got it. Preload is stretch, contractility is squeeze strength. What's the third one? Afterload.
Afterload. This is essentially the pressure that the ventricles must overcome to eject blood. It's the back pressure exerted on the SL valves by the blood already in the aorta and pulmonary trunk.
The resistance the heart pumps against.
Exactly. Think of it as the load after contraction starts. In healthy individuals, afterload isn't usually a major factor affecting stroke volume because it's relatively constant. But in people with hypertension, high blood pressure, the afterload is significantly increased.
So the heart has to push harder.
Much harder.
Yeah.
The ventricles have to generate more pressure just to open the SL valves. This increased workload makes it harder for the ventricles to eject blood, which means more blood might be left behind after contraction, higher ESV, thus reducing stroke volume. Chronic high afterload really strains the heart.
Okay, so preload, contractility, and afterload all manage stroke volume. What about the other side of the CO equation, heart rate?
Right, heart rate, HR regulation. We already touched on this, but the autonomic nervous system is definitely the most important extrinsic control. The sympathetic speeding it up, the parasympathetic vagal tone slowing it down at rest.
Nerves are key.
Anything else? Chemicals play a role too. Hormones like epinephrine from the adrenal gland and thyroxine from the thyroid gland both increase heart rate. Epinephrine mimics the sympathetic effect, while thyroxine increases metabolic rate generally, including the heart's sensitivity to epinephrine and norepinephrine. And ions are critical. Proper balance of electrolytes like potassium and calcium is absolutely essential for normal heart rhythm. Too much or too little can be dangerous. For instance, excessive potassium, hyperkalemia, interferes with depolarization and can lead to heart block and cardiac arrest. Too little potassium, hypokalemia, can cause feeble beats and arrhythmias. Calcium imbalances are also problematic.
So electrolyte balance is vital.
Absolutely. And speaking of heart rate itself, there are clinical conditions related to it. Tachycardia is an abnormally fast heart rate, generally defined as over 100 beats per minute at rest. While it can be normal during exercise or stress, persistent tachycardia is problematic because it reduces filling time and can promote fibrillation.
Too fast is bad. What about too slow?
That's bradycardia, a heart rate slower than 60 beats per minute. Now, this can actually be a desirable outcome of endurance training. Highly conditioned athletes often have slow resting heart rates because their hearts are so efficient, high stroke volume, they don't need to beat as often.
So slow isn't always bad.
Not in athletes. But in poorly conditioned individuals, bradycardia can indicate problems like insufficient blood circulation or issues with the pacemaker or conduction system. Context matters.
Right. Okay, so if all these regulation systems fail or the heart muscle gets damaged, what happens then? Heart failure.
Unfortunately, yes. That can lead to congestive heart failure, or CHF. This isn't a single disease, but rather a condition where the heart becomes such an inefficient pump that it can't meet the body's tissue needs for oxygen and nutrients. Circulation becomes inadequate.
What usually causes CHF?
There are several common underlying causes. Coronary atherosclerosis, clogging of the coronary arteries, is a big one, weakening the heart muscle over time. Persistent high blood pressure makes the heart constantly work against high afterload, eventually tiring it out. Multiple myocardial infarctions, heart attacks, leave behind non-contracting scar tissue, reducing pumping efficiency. And certain conditions like dilated cardiomyopathy, where the ventricles become enlarged and flabby, also impair pumping.
Can one side fail before the other?
Yes, that often happens initially. If the left side fails, left ventricular failure, it can't pump blood effectively out to the body, so blood backs up into the lungs. This causes pulmonary congestion and fluid leakage into the lung tissues, pulmonary edema, leading to shortness of breath.
Left failure, lung backup.
Right. If the right side fails, it can't pump blood effectively to the lungs. So blood backs up in the systemic circulation, the body tissues. This leads to peripheral congestion, often seen as swelling, edema in the legs, ankles, feet, and sometimes fluid buildup in the abdomen.
Right, failure, feed body backup.
Exactly. But because the heart is a double pump, failure on one side puts more strain on the other side. So eventually, the whole heart often fails. Treatment usually involves diuretics to reduce fluid volume, drugs to reduce afterload, and sometimes medications to increase heart contractility.
A serious condition, for sure. It's almost overwhelming thinking about everything that has to work right. Let's take a step back, maybe to the very beginning. It's fascinating to consider the heart's journey through life, starting in the embryo.
It really is remarkable. This incredibly complex four-chambered organ actually starts out as just two simple endothelial tubes in the very early embryo.
Tubes?
Yeah, just simple tubes. But they quickly fuse together side by side to form a single chamber or heart tube by about day 21 or 22 after conception. And even at that primitive stage, this tube is already busily pumping blood. Figure 18.23 shows some of these early stages. It then undergoes incredible folding and partitioning to form the four chambers.
Pumping blood by day 22. Just incredible.
And the fetal heart has some ingenious tricks up its sleeve because the fetal lungs aren't functional for gas exchange.
Yeah.
The baby gets oxygen from the mother via the placenta.
Right, so it needs to bypass the lungs.
Exactly. There are two main lung bypasses. First, the foramen oval, an opening connecting the right and left atria. Much of the blood entering the right atrium passes directly through this hole into the left atrium, bypassing the pulmonary circuit.
A shortcut between the atria.
Yep. Second, the ductus arteriosus. This is a short vessel connecting the pulmonary trunk directly to the aorta. Any blood that does make it into the right ventricle and gets pumped into the pulmonary trunk mostly gets shunted through the ductus arteriosus into the aorta, again bypassing the lungs.
Another shortcut after the ventricles.
Right. These shunts are vital for fetal circulation. And then, almost miraculously, they're designed to close at or shortly after birth, when the baby takes its first breaths and the lungs become functional. The foramen oval closes to become the fossa ovalis, and the ductus arteriosus constricts and becomes the ligamentum arteriosum, permanently rerouting all blood through the pulmonary circuit.
Amazing engineering. But sometimes things go wrong there.
Unfortunately, yes. Congenital heart defects problems present at birth are actually the most common type of birth defect, affecting nearly 1 in 100 births. Sometimes they're linked to maternal factors like infection or drug intake during pregnancy, but often the cause isn't known.
What kinds of problems do they cause?
They generally fall into two basic categories. Either they involve mixing of oxygen-poor and oxygenated blood, reducing the oxygen supply to the tissues, things like septal defects, holes between the atria or ventricles, or a patent ductus arteriosus, where the ductus fails to close.
Mixing problems.
Or the defects involve narrowed valves or vessels that obstruct blood flow, forcing the heart to pump harder and increasing its workload, like coarctation of the aorta, a narrowing of the aorta. Some defects, like the serious tetralogy of Fallot, actually combine multiple problems.
Tetralogy of Fallot. Sounds complex.
It involves 4 specific defects, but the good news is surgical techniques have advanced incredibly, and many congenital heart defects that were once fatal can now be successfully corrected, allowing children to lead relatively normal lives.
That's fantastic progress. So, assuming the heart develops normally, what happens as we inevitably age? Does it just keep going strong forever?
Well, like any hardworking machine, the heart does undergo some inevitable changes with aging, even in healthy individuals. Valve flaps, particularly the aortic valve, can gradually thicken and become sclerotic or stiff.
Stiffer valves.
Yeah, which can eventually lead to stenosis. Also, our cardiac reserve, the heart's ability to increase its output in response to stress, like exercise, naturally declines with age. The maximum heart rate decreases.
So it doesn't respond as well to demands.
Not quite as robustly.
Okay.
And the cardiac muscle itself can become fibrosed, meaning some muscle cells die and are replaced by fibrous connective tissue or scar tissue. This makes the heart wall stiffer and less efficient at filling with blood during diastole.
Stiffer muscle, too.
Exactly. All these age-related changes can contribute to reduced cardiac efficiency and increased risk of heart problems.
And things like atherosclerosis complicate this.
Hugely. Atherosclerosis, the buildup of fatty plaques in the arteries, including the coronary arteries, is a progressive condition often starting early in life but accelerating with age and lifestyle factors like poor diet, lack of exercise, and smoking. It's a major contributor to heart disease, heart attack, and stroke, which are leading causes of death in older adults.
So lifestyle really matters for the aging heart.
It matters tremendously. While some age-related decline is unavoidable, the rate and severity are heavily influenced by lifestyle. Regular aerobic exercise, even started later in life, has been shown to significantly mitigate many of these changes. It can enhance myocardial endurance and strength, improve cardiac reserve, and help maintain cardiovascular health well into old age. Diet is crucial too, of course. It's never too late to make positive changes.
That's encouraging. Good advice. What an incredible journey we've taken, really, through the human heart. From its earliest embryonic beats, through its intricate structure and function, its electrical marvels, its ceaseless work powering our entire body, and even how it ages, it truly is an exquisitely engineered double pump.
It really is. Operating with such precision, day in, day out, propelling blood through thousands of miles of vessels, it's awe-inspiring when you stop and think about it.
Absolutely.
And maybe, if we connect this all back to the bigger picture, considering the heart's incredible reliance on oxygen, its unique electrical properties, the factors that regulate it, this raises an important question for the future, perhaps. What more might we learn about its amazing ability to adapt under extreme conditions, or maybe even its potential to regenerate after injury? That's where research is heading.
A truly profound thought to end on. The future of understanding and maybe even healing the heart. Well, that brings us to the end of this deep dive. Thank you, as always, for being part of our last-minute lecture family.